So we are live now. So with your permission, can we start
Yes,
the session?
yes, we can start.
A very good afternoon to all. A very good afternoon to all. I am Nishita from IGCP Group. Welcome everyone who are present on today's live webinar on ensuring safety in spine surgery. I am honored to welcome Dr. Devesh Dholakia as a speaker of today's webinar. Let me share let me share few achievement of Sir. Dr. Devesh Dholakia has done MBBS, MS in orthopedics. He is also orthopedic and spine surgeon at Gleneagles Hospital, Jaslok Hospital, Global Hospital, Masina Hospital, Saifi Hospital, and St. Elizabeth's Hospital, Mumbai. Dr. Dholakia also lecturer at KEM Hospital, Mumbai. Let me share also an overview of today's program. Ensuring safety in spine surgery involves multiple strategies and consideration to minimize risk and improve outcomes for patients. Join us for an informative webinar focused on latest advancements and best practices in spine surgery safety. This session will cover critical aspects of patient safety, surgical techniques, and innovation designed to minimize risk and enhance outcome in the spine surgery. Now, without wasting any more time, I would like to hand over the session to Dr. Devesh Dholakia, sir. Sir, over to you. Please proceed.
Thank you for your kind introduction. I am Dr. Devesh Dalakia. Thank you, everybody. And I would thank especially my senior colleagues, senior consultants, and friends. A very good afternoon. I'm going to talk about spine surgery and how we have made it safe. Before going to that, I would like to talk about the myths which people have and even doctors have about spine surgery. So let's take a few minutes and try to see what is going on about it. Yeah. Or spine surgery is a major surgery. Yes, spine forms a major part of the body. That doesn't mean every spine surgery is a major procedure. Nowadays, most of the spine surgeries are minimally invasive. That is, small cuts, procedures are faster, require less time for recovery, lower risk of infection or post surgical pain. The minimal invasive surgeries at present are conducted commonly for lumbar spinal stenosis, spinal infections, spinal instabilities, herniated disc, and vertebral compression fractures. However, some centers in India and in the world also perform minimally invasive surgeries for spinal deformities like scoliosis, degenerative disc disease, and spinal tumors. People are very afraid to go to a spine surgeon. They always think that once we go them, they will recommend surgery. Friends, surgery is not for everyone. What we achieve, what you are trying to achieve is a solution in a least invasive way, whether it's non-surgical or surgical. Whenever a patient comes to us, we explain the pros and cons of the surgery and the non-surgical modality, and they help us, and we help them to make a decision what is right for them. For example, if a patient is young, office going, and he has a spinal problem which requires rest for prolonged period of time, like a prolapsed disc, which is not possible always when you are working. So, what we ask them is the better to go for surgery so that you can join work at the earliest with minimal problems, like regarding loss of jobs. Oh, spine surgeries are very painful. Yes, for the first 1 or 2 days, it is painful. During that time, we start them on IV medications after surgery, and then we put them on oral medications depending on the pain situation which he is in. Spine surgery takes forever to recover. Yes, some spine surgeries take quite some time to heal. However, the recovery time depends on many factors like age, part of the back being operated, specific procedures being performed, or your overall health of the patient. Example, after a disc or a foraminectomy surgery, the recovery is in a few weeks, while a fusion surgery may take up to 3 months. So before you go for surgery, or even for all my patients before surgery, I'll always discuss prior to surgery what to expect in returns in terms of recovery from work or from the recovery from the surgery and the time when he can join work and can start doing exercises. So the patient and the surgeon should be always on the same page. There's always a common problem whenever I suggest surgery. After surgery, I'll be bedridden for a prolonged period of time. Friends, with minimally invasive techniques and implants available at present, patients are walking the next day. Spine surgery is dangerous. With in today's era where there are good spine specialists, use of modern techniques like use of microscope, developments in anesthesia has made spine surgery safe. Surgery performed for the right reason and under the right condition, the results are very, very satisfying. I would say spine surgery is as safe as flying in an aeroplane. There are daily thousands of flights which reach their destination safely. And occasionally you may have a complication like the one which we had in Nepal yesterday. I would even come to say that it's more safe than traveling on Mumbai potholed roads. Once you have surgery, does it mean that I always need a second surgery? Generally, the surgery is once only. However, after surgery, information is provided regarding lifestyle changes like back care, core strengthening exercises, weight reduction, etc., so that you can continue to enjoy the benefits of surgery. We have 33 vertebrae, 23 discs. We may operate at one level, probably two levels, but the other disc levels may give a problem if you do not follow the lifestyle changes as advised. When patient chooses the right spine doctor, get the right diagnosis and receives the right treatment, is unlikely to require an additional spinal surgery. Spine surgery is very expensive, especially the minimally invasive surgery. Yes, the newer technologies like minimal MIS surgery is expensive, but it is offset by decreasing the length of stay, faster return to work, and this requires decreased expenses. So it is most cost effective, if possible, to go for minimally invasive spine surgery as compared to an open surgery. Always the patient says laser surgery, laser surgery. At present, lasers have not been proven effective for spine surgery. Most of the For the layperson, MI surgery is equivalent to laser surgery, but laser as such is no more used in spine surgery at present. So, friends, how have we made spine surgery safe? Nowadays, the problem is who should operate the spine? Is it an orthopedic surgeon? No. Is it a neurosurgeon? No. It should be a spine surgeon. A spine surgeon is the one who knows when not to operate the spine. We should be able to expose the spine from the front, from the back, right from the cervical spine to the coccyx, and you should be able to use various instrumentation techniques which are available at present. A spine surgeon should have nimble fingers like a neurosurgeon to handle the spinal cord and the nerves, and the power and a orthopedic and a power of orthopedic surgeons so as to work through the vertebrae which surrounds the nerves. In the past, we used we used to have minimal investigations like CT myelogram, which showed a problem in the spine, but we did not know what the problem was. So the thing was, yes, there is a problem. Let's open and see what it is, and we will deal accordingly. But at present, what we do is targeted surgery. We have various modalities available to find where the problem is, what the problem is, and have a guideline before we operate the patient. In today's era, we always do an MRI. So this shows a prolapse disc at L45, which is more on the left side. We have EMG nerve conduction study. If there's in doubt which nerve is being damaged or how much the nerve is damaged and how much is going to the recovery, whether diabetes is the cause of the problem. So EMG nerve conduction study is done and guides us regarding the management of the patient. If we are not sure which nerve is giving a problem, whether it's L3, 4, 4, 5, alpha S1, if there are multiple discs, we do root blocks so as to find out which is the disc which is giving a problem, and then we go ahead with the targeted surgery. If there's back pain and we think it's the facet joint which is giving a problem, we do facet blocks, see if the pain is gone or not, and accordingly help in diagnosing and treatment of facet joint problems. In the past, we had open surgeries like this, where you used to open extensively so that the light could get in and you could see the structures. And this used to give a large scar and leads to a lot of collateral damage to the surrounding muscles. In today's era, smaller incisions are made because nowadays we use loop with headlight, which gives about 3x magnification. And in most of the major hospitals nowadays, microscope is available, which gives light also and magnification up to more than 10 times. But people were not very happy. They wanted to see right inside where the problem was. So the endoscopic spine surgery came in, that is putting the microscope where the lesion is, seeing it, and adequately dealing with it so that the incisions are smaller, recovery is faster, and is a targeted surgery without damaging the surrounding muscular structures. The principle remains the same, that is proper decompression. Whichever technique you use, open, minimally invasive, endoscopic, if the principles are not followed, you will have an unhappy patient. Whichever surgical technique you use, however, the results have been same at the end of 1 year. So the most important is do an adequate job, whichever technique you use, do an adequate job to have a happy patient. In the past, we did not have implants or the implants were too expensive to use for our patients. So after surgery, patient was advised bed rest for almost 3 to 4 weeks, and he had to use a large frame type lumbosacral belt after surgery. With Atmanirbhar, we have good Indian implants of very good quality and very cost effective. The implants have allowed us, the patients, to mobilize. They have allowed us, our patients, to be mobilized the next day after surgery once the pain is less. So once you the pedicle screw has been a game changer. It's a very strong hold in the bones, but the pedicle size is between 8 to 12 millimeters, and the screw which we use is around 6.5 millimeters. So the chances of error is very less. So if you err on the medial aspect, is your spinal cord. If you err inferiorly, is your root which goes down to your legs. So what you used to use to pass was a freehand technique under a Siam, and the chance of error is very less. You see this 6 millimeter screws in a 8 millimeter to 12 millimeter canals. But yes, but as the deformity surgeries increased, that is scoliosis and kyphosis, it was very difficult to pass screws in a deformed spine. So we started doing navigation with Siam, that is called an OAM. We increase the accuracy of passing the pedicle screws and decrease the chances of damage to the surrounding vital structures. This is how navigation works. It's like using like a Siam inside the theater. You know where the screw is being passed, what trajectory to pass, which angle to pass, so that it has more than 99% safety. And with augmented reality available, a few centers in the world has started using navigation with augmented reality. A few centers have started also using robots so as to the robot helps us to get the trajectory so that the chance of error is less. At present, robots are not available everywhere, being very expensive, but sooner or later it will be available to other people. In the past, when you used to do such deformity correction and achieve a great result, at the end of it, we used to do a wake up test. That is, just once you finish the procedure, we used to wake up the patient in the middle of the surgery and told him to move his leg just to see that we have not created any neurological deficit. It is difficult to do also. If the problem is there, it may be too late to get it corrected. The patient may already have paraplegia. So that was the problem with this wake up test. So at present, we have intraoperative neuromonitoring. It is a continuous monitoring throughout the surgery. Data is collected of the spinal cord. So during surgery, if any changes are there in the data indicating a neural damage, we can reverse a step and prevent permanent damage to the spinal cord or the roots. This has made spinal surgery very, very safe at present. In the past, should have carried some punches like this so as to work on the spine. Later, we got burrs. Burr system was available. Different type of burrs were available for different types of work. Diamond burr was used when we are working closer to the dural structures, making the work faster as compared to a Carrison punch. Then came ultrasound bone scalpels, which are available at present, which only cuts the bone without damaging the vital structures like spinal cord or the root. How do we manage bleeding during surgery? These are these are patties, cotton patties, which you just place it around the epidural nerve, epidural vessels to reduce the bleeding. Or we can use gel foam or fibrillar Surgicel to place around the epidural vessels which are bleeding, and this will stop the bleeding. At present, also we have Surgicel powder for smaller vessels. If there's a large vessel bleeding, we can use flow seals. If patient is on ecosprin or clopidogrel, we ask them to stop about 4 to 5 days prior to a planned surgery. Also, we give intraoperative uh, pause or tranexamic acid so as to reduce the bleeding during surgery. So all these measures have decreased blood loss, and nowadays for smaller surgeries we do not require any blood intraoperatively. Many patients are worried. What do you do for dural injuries? What will be the is always the concern. Most of the dural injury are smaller leaks, and we are able to suture it primarily with 6-0-proline, and over that we put a fibrinil glue so that it prevents breakup of the suture line. If there's a large area of dural leak, you are not able to suture, we have dural patches like this. Where you place the patch over the area of the leak and it will heal like a normal dura. In the past, we used to use a lot of bone graft, auto bone graft, that is from the iliac crest, sometimes on the ribs, sometimes on the fibula, so as to achieve fusion. This not only increase the surgical time, but also increase the morbidity of the patient, more pain, difficulty in walking for a few days, etc. So to overcome these problems, we started using allografts, ceramic granules, grafton putty, also called as demineralized bone matrix, and bone morphogenic protein. All these are available in India, though they are a little more costly, but they are available if required. To decrease the chances of infection, see that the diabetes is well controlled. You should have a good OT setup with good OT equipment, laminar airflow, and good OT staff who practices who practices uh, proper cleaning, etc. Use of antibiotics pre-op and post-op is must. With minimally invasive surgery, there is less cuts, less tissue damage, so less chances of infections are present. Friends, with a good with a good anesthesia department, we are able to do prolonged spine surgery under hypotensive anesthesia, making it safe even in children. In spite of all investigations available, a clinical examination is a must. Do not treat MRI. Do not treat images. Treat the patient. Talk to him. See what the problem is before you consider surgery. This is a pre-operative checklist before all of our patients who go for surgery. We confirm the diagnosis, see that the patient is fit for surgery by a clinician and by the anesthetist. We have ordered the correct implants. Blood is ready if required. There's an informed consent taken from all patients explaining the procedure, the pros and cons, and the patient is explained in his own words. We also confirm that we're operating at the correct level in the side before we put the patient under the knife. Spine surgery is a team approach to get an excellent result. A team should include a neurologist, anesthetist, a clinician, radiologist, a physiotherapist. If you are doing a lot of tumor surgeries, you may be a part of a tumor team. The friends, the thought of having spine surgery may be scary one, but a successful procedure can be a game changer. Thank you.
Thank you so much, sir, for your wonderful lecture. Now, I would like to request all our participating doctors, please share your questions. Sir, meanwhile, we already received one question. Uh,
Yes.
he wants to know, my father is 70-year-old. He has lumbar canal stenosis L1 to L15 and polyneuropathy, diabetes CKD. He is not able to stand or walk after covering few meters only. He gets back pain due to seating. Can you let me know how safe is lumbar canal stenosis or alternative treatment that's safe with diabetic patients with polyneuropathy?
Okay. Is the patient having is just back pain or also pain in the legs? What is written, madam? Just check. Yeah, the back pain or pain in the legs also?
Sir, only these two questions are written.
Okay. Okay. So whenever when the patient has lumbar canal stenosis, two things have to be kept in mind in such patients. One is whether this pain in the legs is because of the stenosis in the spine or it is because of diabetic neuropathy. So you do an EMG nerve conduction study and we'll find out what is the cause of this radiculopathy pain in the legs and accordingly treat it. If it is diabetic neuropathy, then we have to treat it as diabetic neuropathy and a diabetologist will help you treat it. But if you have spinal stenosis, then he may require surgical consideration if he's fit for surgery. So, if the patient is very unfit for surgery, then we have a lot of medications available to make him comfortable. Or you can, if the medicines are not helping him, you can put him on epidural steroids. You can give him an epidural steroid. You may give temporary or a permanent relief. It is mild. And the last resort is to go for surgical intervention. The patient having just back pain in stenosis and with CKD, rule out osteoporosis. I think that is one of the most common causes of back pain with is osteoporosis in a patient of CKD.
Thank you so much, sir. We received another question. Uh, Doctor wants to know what are the benefits and risks associated with minimally invasive spine surgery compared to traditional open surgery.
The risk remains the same. Okay, it all depends on who does it, how comfortable the surgeon is with minimally invasive. With minimally invasive, this surgical scar is small, but the amount of decompression, the instrumentation, all remains the same. There is no compromise on that. Okay, the risk factors also remain the same. Only the advantage is there are smaller cuts, so the healing is faster. There's no blood loss. There's minimal use of painkillers because the cut is small. So that's the advantage. But the surgical procedure remains the same. The risk factors probably remains the same. The most common risk factors I would say is risk of anesthesia, risk of infection, and dural injuries. So with minimally invasive, what we are doing is we are using a microscope. So a hair would also look like a thumb to us. So you can see the structures very clearly, very defined as compared to open traditional surgery. The chance of damage to the nerves are less as compared to a traditional open surgery. But otherwise, the risk factors almost remain the same, whichever surgery you do.
Thank you so much, sir. Moving forward to our next question. What are the essential pre-operative imaging modalities for spine surgery and how do they contribute to surgical planning?
As I showed you, whatever we do, we have to find it's a targeted surgery at present. So we use a lot of modalities to confirm the problem. First is talk to the patient, get a good clinical examination done, and after that, we want to confirm the diagnosis, what we are thinking. We do an X-ray and the MRI. These are most common investigations which we ask for. And if we required for some cases, we may ask for EMG nerve conduction study, or if we feel we can take an opinion of a neurologist and come to a conclusion what the patient has, and then only we offer surgery or a conservative treatment to the patient.
Thank you so much, sir. I would again like to request all our participating doctors, please put your questions if you have any. Sir, another question we have received, that is, how can the adoption of advanced surgical techniques reduce the risk of complications?
Yeah, so advanced techniques, as I said, is at present we are in traditional surgery we are looking at the eye through the eyes. Then came the loop where we had a light source, so the incision became smaller. Okay, and we could magnify up to 3 to 4x the structure. Then came the microscope, where the incisions became still smaller because we didn't want the light from outside. We got the light inside the microscope. So we got the light, we got the magnification. So the incision became smaller. Endoscopes put the microscope right where the problem is. So you see this, now the incisions are smaller, and we get more and more light into the structures, more and more magnification. So the surrounding structures are easily seen. So that there's less damage to the surrounding structures, there's less bleeding, and we are able to handle dural injuries much more easily after this minimally invasive surgeries.
Thank you so much, sir, explaining all these questions so well. I would also like to thank all our participating doctors and patients who have joined in this session. Hope sir's lecture helped in you. So, thank you so much, sir, and thank you, everyone. Thank you, sir, for giving us your
Thank you.
precious time. So, with your due
Thank you,
permission, can
MedTalks,
we
for giving
conclude?
me this opportunity.
Thank you so
Thank you.
much, sir. So, with your due permission, shall we conclude the session here for today?
Yes, yes, we can conclude
Thank you,
then.
sir.
There's
Thank
no
you
more
so much.
questions
Thank you,
anymore.
everyone, for joining today's wonderful session. Have a great day.
Thank you.